By way of disclosures, I am the co-founder and chief medical officer of Cleveland Heart Lab, where you can get myeloperoxidase testing that Dr. Houston spoke about. I'm going to talk to you about the importance of multi-marker approach for defining cardiovascular risk and really kind of the direction in which things are going, I think, to really figure out who, when we see patients, really have a risk of having a cardiovascular event and those who don't. If you take the biomarker space for cardiovascular risk assessment, we would agree with many that it is a rather complicated space with many options, but you can really divide those options into three general buckets, if you will. One is long-term risk, which is really a cardiac, classic lipid panel. Classic lipid panel, which the guidelines tell us to measure in the early 20s of our patients. Clearly, if a 22-year-old has an LDL of 400, 450, they have a lifelong problem, and we need to get on top of that. If we look at advanced lipid testing that Dr. Houston so nicely reviewed, they're important, but they're defining our midterm risk, perhaps on the order of decades, and something we need to address. And many of us would argue in the end they're mostly measuring ApoB and ApoA1. But regardless, it's important to define what your particle number is, whether you use just direct protein ELISAs or particle number. And then there's the near-term risk, which is really defined by inflammatory markers. And it's these inflammatory markers that I want to speak to you about today. It's important to note that inflammation and atherosclerosis is a very old concept, early on put forth by Dr. Russel Ross in 1976 when he put forth the response to injury hypothesis for atherosclerosis, in which he argued that the artery is injured, and in response to that injury, inflammation sets in that really sets up the disease process. Now, I would suggest to you that we have spent a good 3 to 4 decades focusing on the first leg of Dr. Ross's hypothesis and really focusing on injury and targeting cholesterol, LDL, and trying to raise HDL. And we've clearly had a very significant and profound effect on atherosclerosis in that the number of ST elevation MIs are down 60 to 70% in the last decade. But we're now at a point where about half the patients, and by my own clinical practice, more than half the patients who present with myocardial infarction, in fact, have normal or controlled cholesterol levels. Either genetically, by drug therapy, or exercise and lifestyle, their cholesterol levels are pretty well controlled. So we can no longer see Mr. or Mrs. Smith in our office put our arm around their shoulder and say, you know, your LDL is low, your risk is low, and it's unlikely you'll have an event. Because that is, we've decreased the number of people who have those types of events so significantly. So we would suggest to have the next profound effect on the risk or identification of patients who are going to have coronary events, we really need to look at the second leg of Dr. Ross's hypothesis, and that's inflammation. And there's several trials and very good biology now understood for the importance and the utility of this. Probably the best is the Jupiter trial that Paul Ritker and colleagues ran. It was a seminal and now a classic trial where they took patients who by the current guidelines did not belong on statin or cholesterol-lowering therapy, yet they had significant enough risk that their CRP or their high-sensitivity CRP were all above 2. So not based on lipids, but based on an inflammatory marker, these patients were enrolled in a trial in which they were randomized to statin therapy or placebo. It was a trial set up to go for 4 to 5 years that was stopped in under 2 years due to excess benefit, and that excess benefit was survival. But what the trial ended up showing, importantly, was that placebo patients at Unity and patients who were treated with statin but did not get their LDL under 70 or their CRP under 2 were no different than placebo. But if their LDL was less than 130, less than 70, or their CRP was less than 2, they had significant benefit. But interestingly, if their LDL was less than 70 and their CRP was less than 2, they had yet more benefit. And certainly I was guilty of it, I'm sure many of us were in the past, where I thought I could know what my patient's lipid status was or know what their inflammatory status was, but I didn't need to know both, because after all, cholesterol gets in the artery wall. As Dr. Houston nicely showed, it becomes modified or oxidized, it injures the wall, it starts the inflammation, and since one is linked to the other, I don't need to know both. But in fact, these data and many other data I'll show you demonstrate that if you choose to know just the lipid side of your patient, or you choose to know just the inflammation side of your patient, You are choosing to know only